to do that. Okay. So we're not going to be streaming to YouTube tonight as we have in the past. The county administrator is giving his budget presentation to the legislature, and we didn't realize we can't stream two things at the same time with our current setup. So we're recording this, and it will be recorded and then posted to our YouTube site after the meeting's over. So it will be there for folks to view if they want. What that does mean is we don't have to take the extra steps for executive session. I had sent you a separate Zoom link. You can't pause a YouTube recording, and so we were going to have to leave this Zoom, go to another one while that one continued to stream on YouTube, do executive session, and then come back. We're not going to have to do that. I will just pause the recording on this, so please remind me to do that when we get to executive session. And then once we come back out of executive session, we'll just start recording again, and then that whole thing will get posted up to the YouTube site.
Larry, do you have a question?
How many people actually watch the YouTube? I'm just curious.
Yeah, it's less than 10.
Okay. Totally hysterical watching us talk.
If it makes you feel any better, there were only 6 other people watching Jason's budget presentation with me 15 minutes ago. So
I've watched the county legislature before through the YouTube channel. I'd probably be watching him tonight, but I'm here instead.
All right, well, why don't we start our agenda? One of the things we need to do is approve the minutes from our July meeting. They were attached to the email that Karen sent out. Can I have a motion to accept those? Larry? And pardon me?
I move that we accept them.
Okay.
Second it.
Second, okay. Any discussion about them? Any corrections? Okay, yeah, I think they were very thorough. Thank you. Okay, all in favor of accepting the minutes? Show of hands, okay.
Aye.
I think that's unanimous. Elise, did you have a comment?
Sorry, no, I just said aye because my camera's not on.
Okay. Thank you. All right, so they are accepted. I had one board correspondence I wanted to share with you all. Harmony has been in touch with me and has requested a leave of absence from the board for personal reasons. There wasn't a specific time frame that she gave, but I'll certainly check in with her and get a sense of what that might be as far as a time frame. But I wanted to let you all know about that. So that's one piece of information. The next, I'm just looking at the agenda, I think we have the commissioner update a couple of times. So I'm gonna skip the first one and go to subcommittee reports, and then we'll hear from Frank. So if, Tom, can you give us an update on anything that's happened during meetings since we met in July?
I can. We have been addressing the issues of concern and looking for gaps in service for our clients and patients. In the June meeting, we had Joe Smith, who's the head of chemical dependency program at TC3. He explained the program that leads to the designation of case mix. We were also addressed by Jessie Cohen-Phillip from REACH, and she explained the various aspects and endeavors of their treatment program at REACH. In July, we had no meeting. August, we were addressed by Rick Shaw of the Tompkins County Mental Health Department. He addressed the various housing issues and options for the mental health constituents. We also were addressed by Emily England from STAP, which is Southern Tier AIDS Prevention. And she spoke to us regarding the needle exchange program. In September, we were addressed by Mindy Thomas, who explained the various courts in Tompkins County and what they deal with addicted clients and those with mental health issues. Our second speaker was Carmen Gee, the founder of Second Wind Cottages in Newfield. He explained how his 18 cottage program supports the recovery efforts of male constituents. Our plan in October is to have Robert Scott address us. He is the coordinator of CPEP, which is the Cornell Prison Education Program in Auburn. And he'll talk to us about the various levels of education that they provide for the inmates there for education prior to release. And these men also can have get degrees from Cornell. And the second speaker will be a representative from Cody in Portland, and she'll explain the Cody process using their van, which is available through Collin County and all the way up through Herkimer. And it's a process, the van is available for mobile assessment, evaluation, medication, medical assistance, and transportation to rehab if need be. And I'm in the process of trying to come up with some ideas for November, and it'll work. Thank you.
Any questions for Tom? Sounds like you're having some really informative presentations. That's great.
Well, yeah, it works.
Good, good. Okay. Elise, can you fill us in on your subcommittee?
Sure. So we did not have an August meeting, and then we met last week. Our agenda has been pretty standard lately. We've kept the focus on updates to services in light of COVID and a gradual return to services, especially day services for people with developmental disabilities. And we have also made space in the agenda to keep tabs on the impacts of cuts. OPWDD has cut funding. Pre-COVID, there was a cut to certain waiver services that agencies were already grappling with. And now there's also a 20% with what the state is describing as a withhold on non-waiver services, which mostly impact community residences, as I understand it. So I think, we're just going to continue to monitor how that's going to shake out in terms of the impact on people with developmental disabilities in the county. I don't think the agencies necessarily know yet the impacts that's going to have, but it could be significant, I think, at a time when their costs are increasing and their revenues are decreasing. Sheila, did you have anything to add to that?
No, that was very thorough, Elise. Just one of the things I'm thinking about as you were talking. We probably want to monitor now that students have returned to school virtually in Ithaca, both in person and virtually in other
I
places.
can't hear Sheila.
You can't hear?
Yeah, I can't hear you.
Kind of
Very
soft.
soft.
Yeah.
Better.
Yeah, that's better.
Okay, I'm sorry. I'll get up a little closer. So I think we just need to monitor the need for services, mental health services among students, families, even staff as students return to school. I would anticipate an uptick, quite honestly, in mental health needs. So I just think we need to be mindful of that.
Okay. All right. Any questions for Sheila or Elise? Okay, thanks. And Larry, can you update us?
So the mental health subcommittee meets tomorrow, and it's a continuation of a discussion we had in July and hope to have in August, but we had to postpone an August meeting. We don't usually meet in August, but we were going to, but we postponed it. Anyway, tomorrow we're going to be talking about the status of peer support services in Tompkins County, and I assume express our support for the importance of peer support services, especially in a time of cuts and reductions and constrictions in service. And we'll probably hear a little bit more and have questions and answers with Josephine Cohen Gibson about the changes to the Jenkins Center, and also from other providers who happen to come, how their peer support programs are going. So that's where we are.
Great, thank you.
Mm-hmm.
All right, Frank, can you, we have a lot of items on the agenda for you to cover, and we certainly would want to add health homes there in the plan. So in whatever order you want to start that.
Well, let me run down them in the order that's on here. It's probably the quickest way, and leave the budget for the last, because you probably have the most questions there. Quick COVID-19 update generally for the community. I think everybody's aware we saw a spike about a week ago related to a cluster of Cornell students. We've almost gotten to the end of that cluster. You may have noticed over the last couple of days that we've released double-digit people from isolation. So that means those 10 days have kind of expired for those that were positive. We have also seen that most of the positives that have come from that were folks that were already in mandatory quarantine, which means we identified them during the contact tracing, which is good, because when they did turn positive, they had not been exposing anyone because they were already in quarantine. Cornell's been an amazing partner in helping to get the students what they need. They provide them housing and food and all the wraparound services that they need in order to isolate and quarantine successfully. So the number of active cases that we have is starting to reduce down. I think we're at about 50 or 55 right now. So that's the good news. We've had, a handful of cases over the last week or so in the community at large, but most of the cases that we've seen, I'd say probably 75% of them have been related to higher education. So we kind of expected a bit of that in the beginning. We've weathered this storm fairly well so far, and we're hopeful if everything continues in the right direction, we'll be heading back towards the prevalence that we were used to seeing, where maybe 1 or 2 cases a day is what we're dealing with. So yeah, it was a very busy time for us for the last couple of weeks. The nurses, the whole department, quite frankly, got called into action because the numbers were so large. And I think we've weathered it. And I think the message has gotten out to the students that this is what can happen if we don't do what we're supposed to do. So we'll just, keep our fingers crossed that we head in the same direction. Obviously, the next big hurdle is going to be K through 12. Several of the districts started last week or this week with in-person instruction in some form or fashion. So, so far, so good. We will continue to monitor that and work with the school districts as we progress forward. So all in all, things are still good. I would suggest that any business or organization that can open and reactivate within the guidance that the state has lined out should really consider doing that. We've got to get back to as close to reactivated as possible, and our disease prevalence is low. And so I think if we do it slowly and smartly and continue on that path, we'll be successful. Does anyone have any COVID-related questions before I move on? Sheila?
Just a very quick question. The students at Cornell, are they quarantining or are in isolation on the Cornell campus or in the community?
Most of them are on campus in the Statler. When the Statler got full, they did use an off-campus hotel as well, but there was less than a dozen people off campus, I think. Paula?
Is anybody considering, especially if the schools are going to be opening, wastewater testing?
Yeah, there has been some of that going on. Early on, that was identified as a potential opportunity. I don't know the full extent of what's happening, but I do know that we've been partnering with SUNY Upstate for, I think, almost 2 months now to help collect samples here locally.
Great, thanks.
Elise?
I was just wondering if you have any insight into why the data on the Cornell COVID dashboard lags by so many days. I realize it's not your responsibility, but I wonder if you knew.
Yeah, so it lags by 2 days from when the person tests positive generally. And the reason for that is that Cornell, at my request, is not reporting anything as a positive case until we have confirmed it as a case. So the way that it happens is you get tested. Generally, we get the results either later that day or the next morning, and then our nurses do our case investigation. Sometimes in a case investigation, a positive test result doesn't result in a case, particularly with college students that were returning. Some of them may have been positive a month and a half ago, but are still testing positive, but they're no longer contagious. And so we wanted to make sure that we went through that process of confirming that it was a case. Then we report that to Cornell, which creates that day lag, and they're essentially reporting it the next day. So that's really what is causing it. It's not they're withholding information. It really is we ask them, we don't want to report something as a case and then have to take it back, right? Because that would just be really confusing. So we want to make sure we know it's a case. That's the way we've done it on our website from day one. We don't report anything until we know for sure it's a case. And then when we're sharing information with them, it creates a little bit of an additional lag.
Yeah, and the Cornell COVID dashboard, it stays static for 4 to 5 days at a time. So it's definitely like, as opposed to the health department dashboard, which is updated every day after 5 p.m. Every day that the data points move, the Cornell COVID dashboard often does not move for 4 or 5 days. And so it feels like it's sort of a useless exercise in data sharing because it lags so many days that it's like you could have had another cluster and not even know it. So I think that's been a little frustrating for the Cornell community. I know as an employee, I felt that's a little frustrating.
Yeah,
Also,
can
I add to that?
Go ahead, John.
Yeah.
I also want you to know that the students thought it was a conspiracy by Cornell. That was the rumor that went out very quickly, that it was an effort to keep the numbers down.
Okay.
It was a lot of hard work to do damage control.
Yeah, so I can't speak for Cornell. All I can tell you is that we report every positive case in the county, whether it's Cornell, Ithaca College, or just another member of our community, and we've been doing that consistently from the get-go. So yeah, it is a check. My understanding with Cornell's dashboard is they're updating it Monday through Friday, and that the only time that there's a gap is on the weekend, and they do it at the end of the day. As far as whether they're maintaining that, you'd have to take that up with them. Maria?
I wondered about testing. I understand there's other kinds of testing now besides what has been the standard of care. And I wondered, are we in Ithaca moving in that direction, or are we sticking with what we've been doing?
No. So the standard that we started with was nasal pharyngeal, which was the deep nose, very uncomfortable test. That is still happening at the drive-through off campus, at the mall primarily. they were able to validate anterior nares testing, which is the front of the nose. So for those folks that are getting tested on campus, they're just doing 2 swabs in the front of the nose, and they are very close to validating the saliva testing. So we're keeping our fingers crossed that we could be making an announcement about a switch to saliva testing here in the near future. All right, I don't see any other hands. So next thing, trends related to the clinic. Clinic is still operational. The governor extended the executive order that allows us to do telemedicine and phone services. We have applied for a permanent telemedicine license. Obviously, the state is very backed up in getting those out to be approved. But whenever it happens that the executive order is lifted, we stand prepared to be able to continue to do video telemedicine. What we're unclear about is whether they're going to allow us to continue to do telephonic therapy. And most of our clients have chosen telephone as the main means of communication for their therapy sessions. I think we're like 60 to 70% phone versus video. So it's a big number for us, and we're watching very closely to see if we'll be able to continue doing the phone. But we are very much prepared to continue doing video telemedicine for the foreseeable future, even post the COVID rule changes. As far as clients and where we are, we have started to see an increase in new intakes into the clinic. It's not where it was pre-COVID. So we still have capacity to bring more people in. We've been doing some messaging. I've been on the radio a couple of times, trying to get the word out, encouraging people to seek out help before it becomes a crisis, particularly those individuals that might not have interacted with the system previously. Again, encouraging folks to seek service. And talking with Family and Children's, they're in a similar boat. They have seen an increase in intakes, but not quite yet where we were pre-COVID. So there is still definitely capacity in the community, and we're going to continue to encourage folks to take advantage of that. As far as hiring in the clinic, the deputy commissioner position was re-advertised. It either just closed or is closing soon. So we'll be looking at those applicants again to see what we have there, and be bringing the hiring committee back together to review those and see where that gets to. We did have a nurse practitioner that has resigned. She was the brand new one. That was an internal nurse for us that got her license while working part-time with us. She started with us for a bit, went out for a leave, and then submitted her resignation. So we are recruiting for another nurse practitioner. The good news is we do have Dr. Miller up and running remotely. So we're working a plan so she will be able to continue to serve clients from her home in Texas with us via telemedicine. So we're working to maintain that. We are still recruiting for a full-time nurse practitioner as well as a psychiatrist. So both of those are open and active, and we continue to look for candidates. Any questions about the clinic? Sheila?
Just a couple of questions. First, you talked about that telephonic therapy. Is that is the experience that you're having here in Thompson County reflective of what's happening across the state?
Yeah, I think so. Certainly in county mental health clinics, as the safety net provider, I think we're finding that county clinics are finding that people are more interested in telephonic. We have worked with anyone who is interested to try to get them access to do it whichever way, whether it's to try to do a video or to even have a telephone if that's necessary. So we have gone that far to make the opportunities available.
Well, given the fact that there's so many people that are choosing that option, do you think that'll be impactful in terms of the state's thinking about this?
Yeah, I don't know, because the one thing we don't know about is the efficacy of it, right? I mean, it is still fairly new. There was some evidence about video telemedicine. I think we still have work to do to find out about telephonic. But for the foreseeable future, I think we're going to be doing it this way. We are trying to encourage people to move to video, particularly with our therapists that are more comfortable with it in preparation for the potential that the telephonic might go away.
The second question was, you spoke about you're not family and children's and the clinic. They aren't at the pre-COVID levels. Any thoughts? Any thoughts about why people are a little bit more reluctant to seek therapy? Are they still fearful around COVID, or the word is not out, or the word isn't out there that you are, providing services?
It's probably a little bit of all of that, Sheila. I think there's probably still some fear of going to a building that you're not used to. There's obviously still stigma associated with this, with mental health services, unfortunately. So I think all of that kind of plays a role. We have been putting a lot of effort into getting the word out that we are available and ready to see folks. But I think it's the same work that we had to do pre-COVID in reducing stigma, encouraging people to seek service. Travis?
Is the preference for telephonic sessions, or is it reflective of people's limited access to the internet?
I don't know that I can answer that question for certain. I would imagine some of it is. Some of it's also ease, right? I mean, one of the things that we found is that for some clients, they have a much better show rate doing it telephonically, right? Because all of the other barriers that prevented them from coming to us are kind of gone. We have also had issues where people call for their therapy session and the therapist hears they're in a room full of people, right? Their roommates or whatever it might be, and they have to have conversations about, we need to get to a private space. You need to be dedicated to this conversation and really invest in it. So there's been a lot of work to kind of navigate what the challenges are. But I would imagine that access to either broadband or video technology is certainly playing a role. I just don't know to what extent.
Okay.
All right, what's next? Priority plan. So we're not doing the priority plan this year. The state has sent out some surveys that we're working on, essentially wanting to know how COVID has impacted our services. So we're doing that. They're sending it to different agencies as well to fill those out. And I think then they're going to kind of compile it all for their usage. So we're working on that. On a side note to that, we have sent a survey out to all of our contract agencies about the potential for the 20% withholds to become 20% ongoing reductions. We want to know kind of what the impacts to those are. Just so you know, what I have told them is that they need to look at their operations, and what we want to do is prioritize. We don't want to cut everything to the bone so we can't do anything well. We really need to be looking at what are we going to fund and do well, and what might we not be able to do if that's the case. So they're doing that. We have some flexibility to move some of the monies around, not a lot, but a little bit. We would certainly bring that to all of you before any final decisions are made about how we might shift the funding if the reductions are in place. So it's kind of a two-step process. We're asking the agencies first what their thoughts would be around it, and then ultimately we as a county are going to have to look and decide if there are shiftings that we want to do more broadly in order to prioritize one thing over another based on those reductions. For some organizations, it won't be a lot of money because they don't get a lot of money, but for others, it's a big chunk. And so we're going to have to figure out how to address that. Sheila?
It's probably premature, but do you know right now what kind of criteria you would use to make that determination? Is it like number of clients served, or, you know, lack of services in a particular area? I mean, how do you think you're going to probably make that decision?
Well, I'm hoping you're all going to help me make those decisions. The priority plan from last year would be a place to start, right? The areas of importance. I think what we're likely gonna be looking at is the number of people served, the priority of that population, the priority of the need of that particular population. It's not gonna be easy, right? None of these budget decisions are easy, and nobody wants to make the reductions. But it's always been my feeling that if we cut everything to the bone, we're just gonna limp by and nobody's really gonna be getting anything good, versus let's make the hard decision, fund what we think is most important so it can be done well. And then when we have, you know, opportunity in the future to fund other programs, then we expand again. But obviously I would take advice from all of you on how to prioritize. Paula?
I was wondering how good a job we're doing in tracking savings that programs provide. So off the top of my head, you know, I think of like mental health court. Those people are not going to jail, and jail is expensive. So how good a job is the county doing of keeping track of savings from programs as well as cost of programs?
Yeah, so that's a good question, Paul, and I don't think we have those answers. I think obviously if we're having conversations about what we're going to fund and not, all of that would play a role in it. What I can tell you is mental health court is fully locally funded right now. And so it is in our budget to fund, and wouldn't necessarily be impacted by the 20% reduction. And it already accounts for the county reduction that we were required to make. So it's I think right now our functions within the department, the things that we fund are, because we get a small amount of money from the state, but it's not a huge. It's really going to be more about the contract agencies where we're going to be seeing the reductions be more meaningful. All right, other questions about that? It's actually a good segue into the next issue, which is the budget. Oh, I'm sorry, there's a chat that okay. Jana put in the chat that OMH was talking about telephonic being beneficial, so there's hope that it might continue. So shifting to the budget, Jason is giving his budget presentation as we speak to the legislature. We were required as a department to find a 12% reduction in our county share, right? So not any of the other monies that we get from the state or revenues. Obviously, we had to estimate our revenues as we always do, but from a county contribution, we had to find a 12% reduction. So that kind of brings us to health homes. I think everybody's aware because we've talked. Jan, did you have a question before?
I just wanted to ask, when you say we, do you mean public health and mental health together yet for the budget, or are they both considered separately?
No, they're still both considered separate budgets. So we took 12% from public health and 12% from mental health. They're still separate budget units within the county's system.
Thank you.
Yep. So, so in order to achieve what we were doing, there's a couple of pieces of good news. One is that the clinic was heading in a really strong direction. We've been talking about our revenues and our efficiencies and what we've been able to do. And so we had actually built a pretty significant, amount of growth into the department, expecting those revenues to continue to grow for this year, right? So when we were looking at reductions from this year to next year, it wasn't as dramatic as it might have been if our revenues were, say, going in the other direction. So that was the first bit of good news. So all of the work that the staff has done around efficiencies and revenue has really helped us navigate through this year and likely next year, particularly for the clinic. The challenge that we had with health homes was in order to continue doing health homes, we were going to have to continue to support them from a county perspective, and those cuts were going to have to come somewhere else, right? So in the health home program for almost a year now, the program director position has been vacant. We did that in order to try to cut expenses and see what we could achieve from a revenue perspective to try to get sustainable. So we put the money into people doing the work, and only we're working with a senior caseworker. The Sharon, as the deputy, was serving kind of in that leadership capacity until she left. And then it was Jeremy and I kind of working with Maria Pena, in the interim. It was not an ideal situation. For us to continue that program, we would have had to fill that program director position. They just couldn't continue to operate without the appropriate support and leadership. And so that would have added cost to where we already were in a negative situation. I think everybody's aware that this is a subcontracted program. It's not a mandate. The Health Homes of New York is the entity that is required to make sure these services are provided, and we contract with them. We have been subsidizing them since the shift from the old case management mental health program to health homes. The county has subsidized that program. The intent in switching to health homes was to reduce costs for the state to these programming. And we believed in order to do that successfully, we needed to have the appropriate staff with the appropriate credentials and pay them appropriately. Where we've gotten to is that the model that the state has developed with the reimbursement methodology that they've created, we would never get to sustainable. Our staff has busted their butts, excuse my very clear. They have worked really, really hard to get as much productivity out of the staff that they have, and the revenue still does not get to make what is a sustainable budget number for the program. It's just not sustainable. The other entities that are doing this work are paying their staff significantly less than we are. I don't think we're overpaying our staff. I think the program is not designed appropriately to support the type of work that needs to be done from a financial perspective. And with everything that's going on, the 12% reduction from the county that we had to find, the potential for 20% reductions from the state that could impact that program, as well as any reductions to the reimbursement rate that the state might implement because of their budget problems, there was nothing positive that led me to believe that we were going to be able to achieve sustainability. So that is why I made the recommendation to end the program. One, it allows us to not have to take additional reductions in our other safety net programs that if we stop doing, likely nobody else will do. Our clinic, our PROS program, health homes has to make these services available to these individuals. They are mandated, they are paid to do it. They will contract with another agency. The Southern Tier AIDS program, well, there's STIC, Southern Tier Case Management, they've got a different name now, but they are already doing some of this. They might expand. Honey might find another entity from another county that might expand into Tompkins to do the work. But it's just something that we wouldn't be able to do without county subsidy based on the way the model is designed. And so in these times, I felt it was more important to be able to fund and not have to take as much reduction from our clinic and allow Honey to find another contractee that can make it work within the model that they've designed. There are 10 positions that are in that program. 7 of them are currently filled, right? So this will negatively impact 7 staff. The county has committed to a full-time position somewhere else in county government for all 7 of those staff. In fact, Jason and HR, with a couple of department heads, including myself, have been able to find other vacant positions that are not being removed from the budget that these individuals will have the option to take. It won't be an interview. It will be, here's an offer. If you want this position, it's yours. So all of those folks will have full-time work. It doesn't guarantee that it's the same title or necessarily even the same pay grade, but it will be a full-time job with health benefits, retirement benefits, and everything that comes along with it. So while we are going through this negative process, there will not be a layoff associated with it. All of those 7 folks will have the opportunity for a full-time position. We currently are serving 115 people, and this is part of the reason that the model is unsustainable. For Health Home Plus, you can't have more than 15 people on your caseload, and that's about a good number because those are the highest need individuals. And for regular health homes, it's 50. Right, so we are maxed out at the number of people that we are able to have on our caseloads, and it's not financially sustainable. But we are talking about 115 people that are currently on our caseload that will need to be transitioned to another entity to take over their care management. And I'd be happy to answer any questions.
What is the process, Frank, about transitioning to a new provider?
So I have to have those conversations with Honey. Right now, this is a 2021 decision, right? So we have a few months here to figure it out, but we're going to start soon. I had cursory conversations with Honey about our contract about a month ago when we were beginning the budget process, but I did not talk to them about this decision because, quite frankly, I wanted staff to hear from us if this was the route we were going to go before they heard from Honey that, oh, your boss called us and said he's, getting rid of the contract. So we were trying to be respectful of the people in the program that until we were sure we were going to have to make this decision, we didn't want word, getting to them without hearing it from us first. So we will now contact Honey and begin that transition process. The legislature technically still has the ability to fund this. There is an OTR for this program that is part of the budget packet, but neither myself or the county administrator will be recommending to them to fund that OTR. So I don't think the chances are high that it would, but ultimately the final decision isn't until November when they pass the budget. Larry?
So, as I said in my email, I think part of what's difficult for me about this, although I understand and have understood for a while that the model that New York State has saddled the counties with, or the regions with, however they're doing it, is completely unsustainable, and I think they probably knew it before they launched it. I'll just say that I think they could have done a better program if they really wanted to, because of how flawed it is. But what's concerning for me, and I think I'm concerned about the people who will be changing who they're going to. Frankly, I haven't heard very good things about the Southern Cure AIDS program. And I would be very worried if they were to expand to take on these clients. So I'll say that. Secondly, some of these people and some of these people are directly the people who would be in longer-term inpatient hospitalization if this program didn't exist. This program is the final iteration of the state's idea of how to support people with multiple health needs, particularly people with serious mental illness diagnoses. And it feels to me like this is really the reason why we have community-based mental health to begin with. So it's a sad day for me when the county isn't operating or won't be operating those services, because I think it's the entire reason why we exist in the first place. So I feel a real need to say that it won't be okay with me if Honey says, well, we'll just have our workers in another county deal with the people who live here, which is one of the things that I'm frightened about. It also won't be okay with me if we don't get regular meaning the county and the Community Services Board don't get regular kinds of information about how people are doing and whether people are staying out of the hospital. Because these are people who live in the county, and these are people who would have been served in the much better and more effective case management programs, and for us to lose them because the model doesn't work, and for them to lose the connections that they have is incredibly painful to me. So I don't know how one says, as somebody who's giving up a contract because it's not sustainable. But I think as the mental health commissioner and as the community services board, as the local government unit, we need to be clear that we expect for this transition to be smooth, and we expect Honey to do what it can to make sure that services are being provided locally. Because I don't want to hear that people from Cortland County are providing services to people who live in Tompkins County, or people in Greene County are providing services to people who live in Tompkins County. I just don't want to hear that. I want to know that the people who are supporting the people for whom community mental health exists in the first place are getting services from the community where they know people.
And can I just underscore to your point, Larry, that I think that's actually a real danger. That is exactly what happened when Medicaid case management transitioned to the care coordination organizations in the DD system, that initially, at any rate, all of that those services weren't really readily available in Tompkins County. I think little by little they've become more so, but we're talking about a population of people who may not have a whole lot of other lifelines, so to speak, and certainly a group of folks we should be most concerned for.
Yeah, as far as I'm concerned, in some sense, those are the only people for whom I really, at the moment, care. I mean, the clinics and the other services are really important, but these are the people for whom this system was developed in the first place. I mean, these people would be, and I don't mean to keep saying these people over and over again, but they would be in Willard, they would be in, Binghamton Psych Center, and we developed services here because we thought that was a bad idea. And to give those services up is really problematic. And I'm not arguing about the finances of it, I'm just arguing about what can our role be in making sure that people get the services that they need. Because it's hard. I assume it was hard enough for people who knew about the local services to figure out how to do this stuff under the honey regulations or under the state regulations to begin with. If people don't even, if the people providing services don't even live here or know stuff here, how are they going to do a good job? It's a problem, and we've got to make sure that we keep an eye on it.
Yeah, and that has, again, been playing out in the DD system as well, that the providers aren't familiar with the area or the resources or the people in it. And so they've had a hard time making the right connections for folks.
I mean, this feels to me like New York State is failing over and over again to deal with the needs of the people who, you know, caused the whole so-called revolution in community mental health and developmental disabilities to begin with. I mean, they just continue to ignore the people with the most significant and complex needs. It's just ridiculous.
Frank, do you have any thoughts about, can Honey give us information if we're not contracting with them, or how could we stay informed on this?
Yeah. I mean, just like we do with any other agency providing services, we can invite them to any of the subcommittees or to the board. Certainly over this transition period, I will be responsible for explaining to you all what we're doing from a transition perspective. And then from a longer term, you know, keeping up with what they're doing. We as a clinic have a vested interest in keeping people out of the hospital and making sure that they're getting the other services that they need. So we will know acutely if the next iteration of this is not working for our clients that are in our clinic and that are most in need. So I think there's multiple ways to kind of keep an eye on this. We'll certainly work, and I will communicate to Honey the concerns that you guys bring forward, and we'll make sure that there's some mechanism for future connection.
Can you clarify, is Honey through the health department or OMH? Is it?
Yeah, it's a Department of Health program now. So the health home, our health home folks currently, they don't just serve mental health needs. It's the high acuity Medicaid patients, whether it's physical health, mental health, HIV/AIDS, all of those things. There's qualifying criteria beyond just a mental health diagnosis. So when it was switched to health homes, it became a broader program than just mental health case management.
But I bet most of the people have some kind of, if not serious mental illness diagnosis, and some other kinds of mental health diagnosis or developmental disabilities or something. So we have lots of reason to want to know, both from the Southern Tier Case Management Agency and from whatever agency Honey finds to give this contract to. We have a lot of reason to want to stay in touch with those people. And they have a lot of reason to want to stay in touch with us, because we're the local government unit. we can make things easy, or we can be problematic.
I especially like the idea of inviting them to a board meeting early on. And we can
What I was going to say.
some of these things. Yeah.
We can do that.
Jan?
I just wondered if the plan, I know this is getting a little too operational and really isn't my concern here, except based on what we're talking about, are you planning to try to keep back some of the people that you say you have positions for to make the transition particularly smooth, so that if, say, it is somebody who's from out of town that takes the position or whatever, that they're being informed of what the resources are in this area and things like that?
Yeah, not all. and I don't know the one-for-one on every person on what position they're going to be offered, but some of them won't even be available until the 1st of January because of retirements. The county had a retirement incentive, or, you know, so there's a lot of different moving pieces here. So some of it, we may have some folks that go immediately and we have to do some rapid transition. And then we may have folks that are with us through the end of the year, you know, for that longer term transition. So it's really going to be because the first thing we do is we'll have to turn off new referrals, right? That's kind of the first piece of the puzzle. And then those get referred to other places. And then it's about transitioning the clients that are currently on our rolls. And in health homes, there is a rapid churn of people. It's not the same way that it was when it was care management, where we might have somebody for, you know, 5, 10, 15 years. There's a much more rapid try to get them to where they can sustain themselves with the services that they need, and then you back away. So it's a little bit of a different model than you may have remembered from the past. So the turnover of clients happens a bit more frequently.
But even so, those people are the high touch people or the high needs people. I mean, they don't get on the health home roll just because they have a little problem. They're on the rolls because they use a significant amount of resources. And some of those resources could be ongoing case management somewhere. So at the same time that I agree that the clients are different, the reasons why they come into the program are the same reasons why people ended up at longer term facilities in the past. And these programs are supposed to keep people out of the higher touch, higher expensive programs. And I don't think the state has any interest in doing that, really. Otherwise, they design a better program.
Frank, when you say you're going to cut off the referrals, is that once a new provider is in place, so that if there are people that have needs, you can say, well, we're going to refer you to so-and-so?
Yeah, so we don't do the referring. All referrals go to Honey,
Oh,
and they give them to us.
I
So
see.
we'll work with Honey through that transition on, do they have capacity someplace else immediately that they could do it? Do we still need to have some come to us for the short term? You know, we've got to work all of that out to kind of figure out the process. But we don't generally get direct referrals. They're supposed to go through Honey, and then Honey gives them to whatever agency has capacity.
Oh.
Paula?
Wondering how our numbers compare to something like STAP. So would we be a drop in the bucket compared to the number of people they're serving, or would we be a big chunk that they might actually care about?
So one of the things that we have are the Health Home Plus, which was a new designation that has a larger reimbursement, but limits you to 15 cases. So it's a small number. We have a relatively small number of clients because we transitioned almost all of our caseworkers to Health Home Plus because it had the largest financial reimbursement. So it is a relatively small number of people, but they are higher need people, right, that fall into that category. So there's going to be a need for an agency to be able to take those Health Home Plus clients. I did actually get a request from an agency to get LGU approval to expand into Tompkins County for Health Home Plus before we even made this decision. So there was already an entity that was planning to come here, and we would have had no control over that. You know, it's Honey who gets to decide who they contract with and who they refer people to. So there's already mechanisms happening out there, and I think there are agencies that are trying to expand their footprint because it allows for a more sustainable model if you have a larger mix of types of clients and you pay your employees a bit less.
So we should move on with the agenda. I didn't see any other hands up or. but we'll be hearing more from Frank about this, I'm sure, how this is going. Good, thank you. I just wanted to take a couple of minutes to let you know what a small group of us talked about after our July meeting. We had some extensive conversation about eligibility for membership on the board and on subcommittees. So just to give you the update from the conversation that we had, I'm trying to remember who was there. I think Sheila and Jan and Travis. So we had a good group of folks who took a closer look at this issue, and there were two main recommendations that came out of the discussion. We agreed that the board and the subcommittee membership policy should be the same, that it shouldn't be different. And the second one was that anyone affiliated with a licensed or contract agency cannot be considered for membership. And this includes employment and board membership and any other capacity that influences policy or funding. And the nominating committee would determine this information during the first contact with the candidate. One of the concerns that a number of us had was our current challenges with recruitment, and would this further complicate our ability to fill vacancies. So we agreed that an important part of this initiative is really that we need to be getting more organized in recruitment. And we agreed on a couple of steps there. And I believe Frank is going to develop a document for recruitment purposes and contact other leaders in the community. We may also be enhancing the nominating committee a little bit more so that we have more folks who can reach out to other community members. We talked about having a more robust orientation for new members so that it's not quite as daunting to think about getting on the board or a subcommittee. There's so much to learn, and it takes a while to get up to speed, but if we attend a little bit more towards orientation and support for new people, maybe we can address some of those issues. So when we get to the point when we're revising our bylaws, I believe that's down the road a ways, we'll be formalizing these recommendations and making that part of the bylaws at that point. Does anybody who participated want to add anything or not?
I was just going to say that we also talked about more diversity on the board. Certainly that's important. It's always been important, but it just becomes more important all the time. And unfortunately, some of the same people are tapped out all the time because they're the people that are asked to be on several different boards or committees. So we think we're going to have to do a deeper dive, and it may be people that are less experienced with board membership or committee membership. So I think we agreed it was also important in that not just the orientation, but that we convey what being on a board is about or on a subcommittee, so that it's not this unknown sort of nebulous thing to the people out there that we're suggesting it to.
Mm-hmm.
That's about all else I remember.
Sure. Okay, anybody else? Okay. I think we were aware that we currently have at least one person on a subcommittee who is affiliated with one of our contract agencies. So we'll have a conversation with that person about completing their term, but not re-upping at that point.
And that's on the DD subcommittee, correct?
No, it's on the mental, oh, wait, where is it?
There's one on the mental health subcommittee, and I believe, Elise, you mentioned at least one other on your committee, right?
Yes.
Mm-hmm.
So let me see if I can-
And didn't we say they'd finish out their term?
That's right. Yeah,
Yeah.
but not get reappointed after that.
And the other thought that came to me is that we still wanted to encourage very much that people who are representatives of the contract agencies come to meetings, even if they're not a member, because it's crucial to get information from them.
Yes, yeah, that was a good point, Jan, because we really do need that involvement, even if they're not voting members. That's right. Yeah.
And we can even make that a requirement of their contract with us, right? So that they participate or have a representative participate in the appropriate subcommittee.
Mhm.
I like
That would be great.
Yeah, that would really have some power to it. Good.
I know after our conversations about revising the criteria for board members, we had somebody from Reach who was about to be approved. I don't think they get state funding yet, but Frank was indicating that was about to happen sooner than later. So then I believe, Frank, you approached that person and suggested they can come to the meeting, but wouldn't be officially on the committee.
Yes, yeah. Reach is now officially licensed by Oasis. They have their license. Yes, I did talk with Justine and the candidate and explained to both of them that we very much wanted Reach's participation, and they were completely fine with coming to the meetings and just being able to participate in that fashion.
Thank you. On the strategic planning process, I wonder if Kaki or Jan, do you want to talk about our first meeting today?
Go ahead, Kaki, I've talked enough. You got to unmute first.
Yeah, you're muted.
Well, we had our sort of initial organizing meeting today with members from our board as well as members from the Board of Health. Most of our conversation was around just sort of updates on what's been happening within the departments, both at the senior leadership level as well as at the staff level. You know, and everybody had been sort of on hold for the last 6 months or something. It's, you know, everything getting going again and things like that. We had conversation about what the role of this advisory committee is. And there was general agreement within the group, you know, and that we're not, again, similar to what happened last fall, we're not a representative group that is approving something on behalf of the boards, you know, and that as we look at the strategic planning, that's really an operational kind of, well, it's an operational action that's happening, so that we're really looking at what's the advisory role of both this group as well as the boards themselves, so that as the process goes along, we will be bringing back to the board updates on what's happening, as well as the plan starts coming together. It'll not only be going to this advisory board, or advisory group, but we'll also be coming to the full boards for input and, you know, making sure that everybody feels like they're sort of on the same page. We began some conversation about, you know, if we're looking at a 3-year plan, what do we expect to see in 3 years so that we know that something was successful? You know, what are the behaviors? What are the indicators? What is it that's going to tell us that we didn't just have a nice exercise and a lot of Zoom meetings, but that they're actually, you know, are actual outcomes that come from the process. So, you know, more to come once we sort of finalize our conversations and roles and things. We'll be bringing that back to all of you so that we make sure everybody's on the same page and for any input you may have and something that we missed that you see for us.
How frequently are you
Yeah.
meeting?
About every 6 weeks or so, I think.
Uh-huh.
We may meet more often. The real work is being done on the ground. So, we need things to bubble back up so that we can be giving our input on that. It's happening. It's me, the staff groups and the senior leadership group are meeting much more frequently. It's also the problem with, everything's got to be on Zoom. So, you're not going to have a half day or all day meeting, which you might have if people could be meeting. You need to be meeting in smaller kind of pieces.
Our next meeting is October 28th, I believe.
Any other questions or comments? Or say this won't be the last you'll hear of it. We're just sort of getting everything going again after everything shut down last spring.
Thanks, Kaki. All right, we're on to a report on incidents. Frank, do you want to introduce Jana?
Sure. Jana Thibodeau is our Quality Assurance and Improvement Director. What is your title, Jana? I should know. Coordinator. And so she leads our data team, which does amazing things for the department. And one of those responsibilities is coordinating the incident review committee. And it was requested a few months back to kind of get an update of the kinds of things that they're seeing. So I asked Jana to kind of put together a few slides to run through some of the issues that have been identified and some of the work that we've done to try to improve. So, Jana?
Can I share my screen?
You can. Do you have permission?
Yeah, we don't know, can you?
Okay, can you guys see that?
Yep.
Yes.
Okay, and now my present is under there. We go. Okay, so this might be a little bit overkill, and I think it might be overtime, so I will try to go quickly. So just a general overview that we have quite a few members, including Mary. And I am the co-chair with the clinic director, Susan Spicer, who's a nurse. And then there's a list of our other representatives, but generally speaking that we have both community members and representation of supervisors and people from various parts of and various programs in our organization. In 2019, we reviewed 32 cases, and so far in 2020, we've reviewed 10, and we have 2 coming up for the next meeting. So I tried to create a presentation which didn't speak specifically about the people who we'd reviewed in order to maintain that confidentiality, but did talk about the root cause analysis discussions that we've had of what can we change in our processes in order to prevent incidents like this happening again in the future, which is the general purpose of the committee. And then, so I tried to categorize, of the findings that we've had in the last 2 years or a year and a half, I tried to categorize them and then talk about what are the process changes that we've made in a response. And where applicable, I have some data to show how those changes have influenced our outcomes. So some of our corrective actions that came from some of the incidents were to add a secondary substance use disorder diagnosis. So the first diagnosis has to be a mental health diagnosis in order to bill for mental health treatment, but we can add secondary and tertiary diagnoses, including substance use and physical health diagnoses. So in order to have that diagnosis, we have to have a substance use assessment. So then the clinician does an assessment and then adds a diagnosis to the client's chart. So checking for that diagnosis and then also for the assessment in the chart are 2 areas that we've identified where we could improve our processes. And then the idea is that it's called the golden thread, so that if there is a diagnosis for substance use, that is included as a goal in the client's treatment plan. And then it's addressed every time they come to an appointment. And so every time they come, they kind of say, how's your drinking going? Or, 1 to a 10, how are you doing with this? And then the other change that we made was we used to just have one intake. And I think last time I spoke with you all, we talked about this, but we broke the intake into 2 separate appointments. So the first one is with an intake, someone who just does intakes and sort of gets a feel for the client and does the comp assessment. And then the second one is with whoever their assigned therapist is, and that person can have some more time to do some more assessments, including the substance use assessment. And then we also changed our intake note for that second assessment to include some prompt questions that have motivational interviewing and stages of change information so that we capture that and it sort of reminds clinicians to have that conversation. Any questions on that? No. So this graph represents, it's a proportion of the number of people who are newly admitted who have that substance use assessment. So you can see that when we changed our process, that a lot of the people as they were being admitted, we weren't doing the assessment right away, that we were maybe including it later on in their treatment, but we weren't doing it initially. And so this shows, I think, a pretty gradual and substantial improvement in how each client is being assessed for substance use as they come through the door. So this graph, the average number of days between intake 1 and intake 2, and then the orange line is the average number of days between intake 1 and admit. So generally speaking, something that we've identified is that when someone comes through the door, they might be in a moment where they are ready for change or they're asking for help and that we need to respond as quickly as possible. And so this shows, I think, a pretty large improvement. There's also a big gap between those 2 lines because when we did change our process for having 2 intakes, that's represented there. Sorry, everybody's faces on my slide. That coordination of care with external agencies. So this is a big one, and I think that it's tricky because we have limited like agency or purview. Or we have the power to influence, but not the power to control, maybe. But so we have spoken a lot about how that we have clients who attend, who go to REACH or CMC or CARS or ADC, and that we have a limited amount of communication, partly because of client confidentiality, but that we don't necessarily share treatment plan goals or have conversations with those other providers, and that can turn into a paperwork burden for the client. So the client is trying to manage 4 different treatment plans for 4 different agencies, and that's not the best care that we as a provider can be giving. So we talked about inviting community outreach workers to our AOT meeting. That was a recent conversation, and I'm not sure where we're at with it. And we also have discussed establishing and revising memorandum of understanding with external substance use agencies. So at the most recent substance use subcommittee, I believe, I attended with Rich and we proposed it. And the response, the way I understood it, was that we should have more in-depth conversations one-on-one and as a group with those organizations in order to really suss out what our goals are for those memorandum of understanding so that they're meaningful. And what else? Oh, we became, so we did this assessment, which is a DDC-MHT, and then also as part of a mandatory psyches OMH project that we had to pick several substance use related goals. And one of that is that we became we are allowed to distribute Narcan. And so we used to, ADC used to give it to us, and now we distribute it on our own. Any questions so far? Okay. Sorry, I made this presentation for last month, so I have to remember all of it. And so we're also working on our intake process to make sure that we get all of the releases of information for primary care providers when people come in for their first intake visit. So we worked with intake workers to create a checklist to make sure that when someone comes in for their second intake, that the therapist can look through and make sure that all the necessary paperwork is there, so that in case anything is missing, that they can kind of double check and make sure that it's there. We revised our substance use policy and procedure to consider children and youth. And the decision which was made was that anyone over 12, that we will do a substance use assessment for them, and under that, it's up to the discretion of the therapist. Following up with a hospital discharge summary. So this is, I think, again, only partly in our control. It helps us a lot if we have the discharge summary from the hospital, because there's a lot of collateral information, which is important for us to have when we see someone right after they were hospitalized for a mental health or substance use related issue. Something that has helped is that we are participating in a Care Compass Network behavioral health cohort, which actually just ended this month. But that had, I think, a lot of great networking opportunities with CMC and CAP, which is now Huga Health Systems, I think. But I think that opened up the lines of communication, and it allowed us to everybody had a point person who they could call to make sure that we had the paperwork we needed and we were following up. And if someone fell through the cracks, that there was a team of people who were paying attention. High risk list policy, procedure, and process. So this is obviously a really important and reoccurring theme in the incident review committee, just because of the people who have incidents are often very high risk. So we have developed and improved a high risk list, including developing forms in our electronic health record to add and remove people. That Frank emphasized a strong initiative to have a safety plan and a substance use assessment for every person on the risk list, and that we're also doing our violence and risk assessments as part of that second intake. And after COVID, we have started a high risk meeting every Monday morning. And so we review with the psychiatrists and the clinic director and the clinicians, people on the high risk list who need anything from a change in meds to maybe the psychiatrist has gotten a hold of them, but the therapist hasn't been able to, et cetera. That we created a new risk policy that has a rubric. So we defined the criteria. So something that we ran into was that one therapist might identify one person as high risk when another person felt that they weren't. And so you might have one person who was more sensitive to risk and had a very high proportion of people on their caseload who they had identified as high risk, versus somebody else might have a very similar caseload, but the way that they identified it was different. And so we specified, I think, and created categories of what did it mean for somebody to be at high risk, and then also a corresponding rubric for how do we respond. So does that mean they come more often? Does that mean, what does that mean? And how is the treatment different if someone's on that list? So this is some data from that high risk list over the past few months. The blue line is the number of people on the list. The yellow line is the number of people who need a safety plan. So we've done a lot of improvement there. And honestly, those last clients sort of dwindling have very specific reasons. So we send out data to the clinicians weekly and say, hey, you have like a couple of people on your caseload who are on the risk list who don't have a safety plan. And a lot of times it's, oh, I scanned in a paper record, but when you pull the data, that doesn't show up as being a completed form, for example, would be a reason. So some of the remaining ones aren't, they've been looked at, I think. A light blue is a client that they need a next appointment, so they don't have a next scheduled appointment in the calendar. A green hasn't been seen in 60 days. And the dark blue is someone who's been at risk for more than 180 days or 6 months. So the idea is that the risk list is not as meaningful if someone's on it for 2 years. So we really want to be checking in and making sure that it's still necessary that they're on that list, so that it's meaningful, and we have a special response and treatment for the people who are there. Am I okay on time?
It's getting a little tight here.
Okay, should I hurry up? So I'm going to skip this one because unfortunately our care management program is ending, but we did do a lot to collaborate with them and share information. that we provided a NIMERS training for all of the supervisors in 2019 so that they can report incidents. This, Frank, I don't know where it's at. We did talk about improving communication with the police department. And I think this one's exciting that Susan has taken a big initiative to improve, to kind of sharpen caseloads or to make them to have succinct episodes of care. And so we've done a series of 4 different trainings to talk about planning what makes a successful discharge for somebody. So asking them, how do you know that you're successful? So that we can sort of have a milestone when people are done instead of just having them drift off. Also having more meaningful treatment plans. The OMH has now changed the regulations so that that is an ongoing conversation. And we created a levels of care form in our electronic health record to identify different caseloads, and then also what's reasonable. So if you're going to meet with somebody in one level of care twice a week, but you're going to meet with someone else in another level of care once a month, how many people can you have on your caseload? It really depends. So in general, all of those action plans follow a structure, a plan, do, study, act. And I just sort of wrote out the example of the caseload management and how that applies. Yeah. Any questions on that?
Great information. It sounds like what I understand and from being on the committee, it's clear that when issues are identified, the next step is to develop a plan to remedy that and improve things.
Yeah, we're working on it.
Good. Okay, well, thank you so much, Jana.
Thank you.
All right, well, we have one more agenda item. So to move in.
Mary, Travis had his hand up. I think he had a question about
Oh,
that.
did he? I missed that. Okay.
I just wanted to ask, send the PowerPoint out. I wanted to, looking at it, I really appreciated the presentation, but I need to spend some more time with it.
Thank you.
Yeah, good. Larry?
So this is, well, 2 things. One, specifically about the presentation. It would be helpful for us to know, or it would be helpful for me to know the type of incidents that are happening in general, just so I know. So when people are talking about how dangerous people are, I can be knowledgeable about, you know, how things are actually going. So some breakdown that talks about what the types of incidents are would be helpful. At a more macro level, I was reminded today, looking at Facebook, that incidents that involve the police and people and the mental health, or police coming out to deal with people who are might be experiencing a mental health crisis, often come to public attention. So I just want to say, I think the department, and especially as we increase our public presence, has to have a way or a way of speaking about incidents that might involve a person who might be a client, but more in general, speaking about when a violent incident occurs, like the stabbing at the police department a couple of months ago. I think the mental health department really needs to be about putting out messages about what people with mental health histories actually experience, as opposed to this idea that there's constant danger in the community from people who are diagnosed.
Larry, I think you and I are on a task force, and we had this conversation on a different day too. But I think that sometimes an issue that we've identified in the review committee is we're outpatient, and then there's limited inpatient options for people. And so whether or not, especially I think with substance use, that oftentimes jail is the only option, that there's not a therapeutic option for someone when they're intoxicated and
Right.
have mental health issues. So.
Right. Yeah. But I think the health department, mental health department squished together represents a new level of resources that we have about speaking clearly about what the lives of people are actually like, and that mental health crises that come to public attention are not something that happens every week. And we have good processes for dealing with emergency situations. Anyway.
Thanks, Jana.
Thank you, guys.
Okay, we need to go into executive session for a couple of minutes. So I know we're getting close to our deadline, so I appreciate everyone staying a few minutes longer. Can I have a motion to go into executive session? Paula
For what purpose?
and Sheila. We have an applicant to discuss.
Okay.
So anyone who is not a member of the board should probably.
Yeah, Jana, we'll need you to sign off.
Bye, guys. Good luck.
Thank you.
Karen can stay for the purpose of note taking, if that's okay with you all.
Sure. And
Okay.
you're gonna turn the recording off
Yep.
session here, okay? Can I have a motion to adjourn?
Motion.
Motion to adjourn.
Okay, August, okay, all in favor?
Bye.
All right, thank you, everybody.
Thank you.
Bye.
Get back to work on finding candidates.
Yeah. Frank, you got a minute?
1 minute, yeah.
30 seconds. No, I know, because you worked hard. You came up with Tammy, and I was excited about her. It was talk about expanding the nominating committee. Right now,